everybody, and hopefully you've had the opportunity to see webinar 1. This is webinar number 2 in a 4-part series brought to you by Eyes on Eye Care. As you see, this is Understanding and Managing Astigmatism webinar series, and we're really going to be talking about the management of your patients, whether it's spectacles, whether it's contacts, whether it's IOLs. I'm Dr. Kurt Moody. I'm going to be one of the co-hosts today. Little background on myself. I practiced for 22 years in northeastern Pennsylvania in a large MD-OD practice. Then I transitioned back in 2005. I joined Johnson & Johnson, spent the next 20 years of my employment there with them, just recently retired this past December. While at J&J, I was involved mostly in research and development, bringing products to market. The last 5 years of my career, I was in the group that would be doing professional education, bringing seminars like this to you. And now, like I said, the past 6 months retired, so doing a little freelance work right now and working with the great group here of Eyes on Eye. So my co-host, Dr. Erin Roof. Erin, why don't you tell them a little bit about yourself?
Thanks, Kurt. Yep, I'm Erin Roof. I am the chief of the Cornea and Contact Lens Service and associate professor at the Southern California College of Optometry. I have done a lot of work in my career looking at contact lens discomfort and satisfaction with contact lens wear and kind of thinking critically about things that maybe are under-acknowledged when it comes to why our patients do or don't succeed with contact lenses. So that fits really nicely into what we're talking about throughout the course of this series. So I think we'll go ahead and get started now. If you were on the last webinar, the first webinar, we started with a few questions just to kind of get you thinking about some of the topics that we're going to talk about tonight to kind of get everybody in the same headspace here. So we'll go ahead and get started here. So our first pre-event question is, should you prescribe the full astigmatic component to a child less than 5 years of age, and why? So there's a few options there. So go ahead and think through that. Our next question, make sure you put your answer in, is when considering a toric IOL suggestion to a patient, what measurements is important? You can probably see we're going to talk about astigmatism correction from kids to adults today. And finally, the last question is, what is the ANSI standard for vertical prism imbalance in a soft toric lens? You might just have to guess with that one. I don't know if you'll even know. So I'm going to get started here as we're wrapping up these questions. Before we get into kind of the meat of the lecture, there's an option for you to enter questions or comments or thoughts into the chat box at the bottom. And at the end of this webinar, we're going to pop back on the screen and answer any questions or address any comments you have. So feel free to put your feedback in at the bottom there as you're listening in to the webinar. So we're going to talk about things you should consider when prescribing or correcting astigmatism in patients of all ages that might come into your practice. So we're going to get started by talking about prescribing cylinder for pediatric patients. Now, we focused a bit through this webinar already on contact lenses, but I'm going to actually start by just talking about how to think about prescribing SIL in a pair of glasses for a kid. And this is a kid of any age, whether you're seeing them for their first eye exam or maybe a 10-year-old that's coming into your practice. A question that we often ask ourselves maybe when we first discover any meaningful amount of astigmatism in a pediatric patient is, how much should I prescribe and when? Should I cut the SIL by a certain amount, or should I see what they can subjectively kind of adapt to? And the answer to this question is, you should prescribe as much of the true astigmatism that you're able to measure as the patient will accept. So don't fall back on, I should only give them 50% or 70% or a certain percentage in one eye and another percentage in the other. We want to prescribe as much of their true refractive error as possible to allow their eyes to adapt to that SIL and to also develop normally. So you want to prescribe that full cylinder as soon as you find it and to the highest magnitude that the patient will accept. And that might mean maybe prescribing a lower amount initially, checking back in 6 months, and then kind of trying to ease them into the fuller cyl amount as they kind of adapt. It's important to prescribe that full astigmatic amount for a lot of reasons. If the patient has high cyl in both eyes and it goes uncorrected, that could lead to things like meridional amblyopia or just cause them to not be able to adapt to that full cylinder correction as they move into adulthood. And then certainly if the stigmatism is very asymmetrical between the eyes, that could lead to, amblyopia in just one eye. But when you're prescribing a astigmatism power, cylinder power for kids, especially in high amounts, you want to be thoughtful about sort of the materials that you're thinking about for the glasses and the consequences that certain materials or prescriptions might have for kids. So we obviously want to have impact resistant materials, but also think about things like the weight of the spectacle lens. If your patient has high amounts of astigmatism, the orientation of the astigmatism, certain types of astigmatism can be more or less disruptive to sort of the lens within the spectacle frame. And also things like glare and aberrations that can be induced by the lens material itself. So we want to prescribe as much of the astigmatism as we possibly can for our pediatric patients, but we also want to be thoughtful about those spectacle considerations. And one way to be thoughtful about those spectacle considerations is to put that kid in a pair of contact lenses when you identify that astigmatism, especially if it's higher amounts of astigmatism. Contact lenses can eliminate a lot of the downsides or disadvantages that are associated with prescribing full astigmatism for pediatric patients. If the astigmatism is very asymmetrical between the two eyes in a pair of glasses, that could cause some anisoconia. But we know when we put that correction directly on the eye with the contact lens, we don't have those anisoconia issues. So that can eliminate that. Generally, wearing higher amounts of cyl in a contact lens are going to be easier to adapt to than in a pair of spectacle lenses. Oftentimes, the sort of roadblock we come to, though, when it comes to choosing contact lenses for our pediatric patients is either ourselves as the eye care provider or the parent might have thoughts about when it's appropriate for a kid to wear contact lenses. I know a lot of people will say, oh, well, they need to be a teenager. They need to be able to kind of do it on their own without mom in the room. But there's actually a lot of good evidence over the last 10 or 20 years in the literature that has shown that young kids can do really well with contacts. In fact, young kids might do better with contact lenses than our older kids or even our younger adults. The Clay Group, which I'm citing here, has actually done a lot of really great work looking at adverse events with contact lens wear in adolescent and pediatric patients. And you can actually see by this graph here that kids in that 8 to 12 age group are much less likely to have complications related to contact lens wear than our younger teenagers and certainly than our older teenagers and young adults. Now, that might not be shocking, right? When we're talking about those 18-year-olds, those young 20-year-olds. But I think it's good just to see that our young patients, probably because they're under a little more supervision by mom or dad or someone at home, are much less likely to have complications and are able to really wear contact lenses in a healthy way. And especially if you think about an 8-year-old who otherwise would be wearing maybe a heavy pair of glasses or a pair of glasses that they didn't like. I think it's really compelling to fit lenses earlier if that's what their refractive error would suggest or warrants. Here's just another graph showing how risk of complications tends to peak around age 20, not in those younger teen years for our patients. And Kurt, I know you were telling me an anecdote or some data earlier about a study you had actually done overseas. Did you want to talk about that?
Sure. Yeah. Earlier when I was mentioning it to you, I said it was about 12 years ago.
Oh,
The years go by much, much faster than that. It
yeah.
was about 16 years ago. I
Oh,
ran
well,
what was called,
I wasn't gonna like write you up, look you up.
it's actually called CLIP Asia, Contact Lenses in Pediatrics, and it was done in Asia. So we recruited patients that were between the ages of 8 and 12 in both Singapore and in China. So it was Shanghai and it was Singapore. The interesting thing that we ended up finding was very much exactly, would echo exactly what you're showing here, Aaron. The fact that these 8 to 12-year-olds did remarkably well, incredibly low adverse events. Now, all the kids were either fit with moist sphere or moist for astigmatism, but the fact is incredibly low adverse events, almost non-existent actually. But the real interesting finding was in regards to the ability to insert and remove, the time it took to do that,
Yeah.
and whether you were an 8-year-old in Singapore, an 8-year-old in Shanghai, or an 8-year-old in Chicago, because we actually did regular contact lenses in pediatrics in the US, and the data was almost exactly the same. So
That's
I think the
awesome.
bottom line, whether it was adverse event or time for insertion, time for removal, an 8-year-old is an 8-year-old is an 8-year-old. So again, it echoes exactly everything you've got here. So some great data.
Yeah.
Yeah.
That's great to know. And I always like to think, if we fit our kids early in contacts, then they can establish those healthy habits. Like you were saying, an 8-year-old putting it in Shanghai is the same as an 8-year-old in Chicago. They can establish those habits early before they maybe become, I don't know, more of a sloppy teenager or a teenager that might be less likely to listen during my INR training or something like that.
Yeah.
So that's really good data and actually like pretty reassuring as well. And then just also to underline, contact lenses are so beneficial for our pediatric patients. There's been study after study that has shown that kids and teenagers who wear contact lenses have better self-esteem. They feel better participating in sports. They feel better and more confident socially and just have a general better quality of life. And that's for kids with what we would say have like sort of mild or regular refractive errors. But I would argue, especially for those kids that have those higher, more unique refractive errors, not having a heavy pair of glasses that easily break or fall off their face or cause glare or halos or just maybe make them feel like they look different, can giving them the option for a contact lens early can really impact them in meaningful ways that we maybe even have a hard time quantifying in the long term. So don't be afraid to start with a contact lens early in often, especially for those unique refractive errors.
So Aaron, why don't I
Yeah.
transition over and talk a
Yeah.
little bit about contact lens correction?
Yeah.
So when we're thinking about correcting these patients with a contact lens, I think two major types of lenses come to mind. Again, these are for those astigmatic patients. We could either go with the soft toric or we can go with a gas permeable. And as a reminder, the gas permeable lens, the way that is correcting that astigmatism is we're creating that tear lens under the lens, underneath the RGP lens, and that's correcting that corneal astigmatism. So, if the patient's refractive astigmatism equals their corneal astigmatism, a spherical gas permeable lens works tremendous. If I am dealing with the patient whose refractive astigmatism does not equal their corneal astigmatism, I might have to consider something like a bitoric or maybe a back toric or a front toric lens, a little bit more complex. But again, optically really gives a great image quality. And I think most optometrists would agree when we talk pure image quality, you can't beat the quality of vision that you end up getting with that rigid lens.
For sure.
Compared to a soft toric lens, the RGP lens is definitely going to give a sharper image. But when it comes to comfort, that's really where the big difference is. The comfort definitely lies in regards to that soft material. And I think that's why we find the vast majority of patients that have lower degrees, more manageable degrees of astigmatism end up going or opting into a soft toric lens. My general rule of thumb when I practiced was patients that had 2 diopters of refractive astigmatism, more or less, I normally went with a soft toric. Once I
Mhm.
got above 2 diopters, my suggestion to the patient would be to go with the gas permeable. Does that kind of management kind
Yeah.
of your
Yeah, I would
experience?
agree with that. And I fit a lot of RGPs. I do a lot of sclerals and corneal GPs, but I completely agree with you. I don't really start thinking about a GP for correction of regular astigmatism until I see that SIL value go above 2 diopters. And maybe that would have been different maybe even 10 years ago. Modern soft toric lenses are very reliable now. And
Mhm.
so maybe 10 or 15 years ago, we might have edged more towards GPs a little earlier. Now, I think as long as you fall below that 2 diopter range, a soft lens was going to correct you that vision really well. And as we talked about during the last webinar, most of our patients who have astigmatism do fall below that 2 diopter range. You can certainly correct 2.25 diopters of SIL with a soft lens, but you might just want to consider the options, like consider things like, does that patient have a high magnitude of sphere as well as the SIL? Think about things like lifestyle and convenience. Would they prefer a soft versus a GP? Do they need a daily disposable? That kind of thing. So you kind of just think about the unique nuance of each patient once you get over to.
Once we get into those soft torics, there are some interesting things we need to keep in mind in regards to managing these patients. The very first piece of information, I think this is really, really important for us, is the fact that when we look truly at the data, we find that of patients who are currently being fit with soft toric lenses, 1 out of every 4 actually drop out of contact lenses within the first year of being fit. Now, you may end up saying, why? Why do we have a 25% dropout rate, which is incredible in that first year? And there's 2 major reasons. The first one is visual fluctuations due to misrotation, and the second is comfort. So I'd like to talk a little bit about that misrotation, because if we look at the slide that we have up now, this is going to show us the visual ramifications of misrotation depending upon power. So over on the graph on the right, the blue line is showing us misrotation along the x-axis, and along the y-axis is the amount of induced astigmatic error. So the general rule of thumb is 30 degrees of misrotation, you will actually induce the same amount of astigmatic error that you're trying to correct. So again, if I have a minus 75 patient, the ramification will be less than the 175. You can see the dark blue shows you the amount of induced astigmatism you're creating with that misrotation. So it's a whole heck of a lot. Now you may say, okay, 10, 15, 20, even 30 degrees of misrotation, does that really happen? Well, it usually does not happen when the patient's head is perfectly vertical and when we're looking at them in the slit lamp. But when they've got a head that's moving back and forth, as it happens day to day for all of us, we lay on a couch, maybe we're a golfer, we're looking in the rear view mirror. All of these head motions can cause some of these lenses to misrotate more than others. I would give you a little clinical pearl. When I have my patient in the slit lamp, I'm not going to have them look up, down, left, and right, because we know the Achilles heel for most toric lenses is when we're looking in the orthogonal directions, up and to the right, up and to the left. That's going to show you the amount of misrotation a little bit more. So keep misrotation in mind and the stability of that lens in mind.
That's a good tip, because oftentimes patients will complain about not liking the lens, but when you look at them in the slit lamp, it looks great. But I always try to remember the slit lamp is a moment in time, right? Like, and it's probably not a real life moment in time. So that's a good tip to have them look in those orthogonal directions.
Yes.
Yeah.
On the left, this is pretty similar data that you had shown, Aaron, in the first seminar, because it's showing you that if I have a patient that has 0 degrees of misrotation, nice sharp E, if I take just a lens that is a minus 75 toric lens, misrotate it by as little as 5 degrees, you can start to see the amount of blur.
Yeah.
Again, if it's a 175, you see how much blur we're getting.
Yeah. And 5 degrees is not very much
Not
rotation.
very much.
That's hard to even see, really. So that's a good reminder of how critical that aligned rotation is, or no rotation is.
The other point I'd like to just call to everybody's attention, because I think this is really, really critical, because there are a good number of patients that we're fitting with a spherical lens in one eye and a toric in the other. We need to be cognizant of the fact that the majority of lenses on the market, because they're either prism ballast or peri-ballast, create a certain amount of prismatic imbalance. There's prism in the optic zone. So not prism when I'm looking down, prism when I'm looking straight ahead. The information you see here was actually presented at the American Academy of Optometry, and they measured the amount of prismatic imbalance, or the amount of prism in the optic zone of the leading lenses in the market. And you can see the vast majority of them do have some degree of prism in the optic zone. It's only the Johnson & Johnson lenses that are prism-free in the optic zone. Now, first of all, you might say, does it really make that much of a difference? We're not talking about a huge magnitude there. But the ANSI standard in spectacles for prismatic imbalance is 0.33 prism diopters. There is no
Not very, a small number.
there is no ANSI standard in contact lenses, unfortunately. But I call your attention to the little blue note over there on the right, because our binocular vision specialists tell us that prismatic imbalance as low as half a diopter can cause headaches and discomfort. And nobody knows more about visual discomfort and physical comfort than you, Aaron. So, maybe a comment or two on this would be great.
Yeah, I think this is such an under-recognized thing when it comes to toric soft lenses. And it's a good reminder. And, we've been talking about this a lot over the last year or two, and I've been surprised how many people are surprised when this data is kind of brought up. But it's a good reminder that whenever we talk about prism in regard to a soft contact lens, we're always just talking about it in reference to its weight and its interaction with gravity. But prism moves images. We know it does that. We use it very intentionally to do that in other ways in eye care. So this is such a good reminder that, especially for that monocular patient, they might be experiencing vertical prism jump that's 2 times more than what we would accept in a pair of glasses. And what I like to think about is that this amount of vertical prism change is not going to cause diplopia for the patient, but it will cause, as your note here says, headaches and discomfort. And so they don't have the same vocabulary that we do. They're not going to be able to say, I'm experiencing vertical prism disparity. They're not going to say that. They're just going to say, I don't like these lenses. They're uncomfortable. Or they might be one of those 1 in 4 that you were referencing earlier that just drops out, right? That you never hear about again. So, I mean, especially for your monocular astigmats, should be considering a soft lens that doesn't use prism to stabilize it. But I don't know. I think about it for my binocular astigmats too, because what if they've got 75 sil in one eye and 175 in the other? I have to assume they're getting some disparity between the eyes, and I don't want to set them up for failure if I can do better,
Yeah. Yeah, I can't remember the last patient that I had that came in and said, I have astigmatic complaints.
Exactly. Yeah.
But we know what ends up happening.
Yeah. We've got to translate those words for them. Yeah.
Yes. So we kind of summarized, I think, pretty good spectacle management. We talked a little bit now contact lens management. So let's wrap things up and talk a little bit about surgical management. So Aaron, what do you end up counseling your patients when they come in? They're probably maybe an adult. They don't need cataract surgery yet, but they have astigmatism and they're asking you for advice in regards to a refractive surgical.
Yeah. When we're suggesting refractive surgery or we're doing a refractive surgery consultation for any patient, it's multifactorial, right? We're looking at things like corneal thickness, systemic issues, medications, all sorts of stuff. But really specifically when it comes to astigmatism, we obviously want to make sure that it's regular. They don't have signs of irregularity. I typically like to see 2 diopters or less of astigmatism on the cornea just to make sure that they're not going to have any issues with glare, halos, aberrations post-surgery. Obviously, our refractive surgery technology is really great, better today than it ever has been. But still, I want to make sure I'm sending someone out for surgery that's going to have the best outcome possible. And then I'll also think about, kind of where they are, if they're close to presbyopia, if they might want to wait to see how they interact with presbyopia and other things like that. So those are kind of the things I'm thinking about when it comes to astigmatism and refractive surgery.
Yeah, so let me wrap things up and talk a little bit about where we should be having that discussion with our patient if they come in and it's cataract time. So, we've been following a patient for years. That optometry relationship with our patient over the years is critical because the patient's really looking to us for a recommendation. So not only do they want to make sure we're sending them to the best cataract surgeon, but I think it's really our due diligence to go over the options that are going to be presented to them when they're sitting in front of that ophthalmologist and they're telling them, yes, you are definitely ready for cataract surgery. Do you want product A, B, or C? So we should be doing the educating, first of all, to give them information and knowledge so they can make a good informed decision. So when we're thinking about just a standard toric lens versus a standard spherical IOL, The general rule I think that most ophthalmologists are following is if it's a diopter and a half or more astigmatism, they're definitely making the strong suggestion for a toric IOL. And a lot of ophthalmologists are suggesting even starting at 1 diopter. These toric IOLs do remarkably well. They're very stable. They give great vision. So when I have that patient in my chair, the first thing I'm going to have to determine is, are they a candidate for these lenses? And your decision is based upon the amount of corneal astigmatism. Now, this is important because it's not
Yeah,
based upon the refractive astigmatism. In
right.
our last seminar, we talked about the fact that as patients age, there's an increase in against the rule astigmatism. Um, it goes from being with the rule to against the rule, and an increase in the magnitude of that astigmatism. That's refractive astigmatism. What you want to measure in the exam room is the amount of corneal astigmatism. If
Right.
that amount is a diopter or more, in my opinion, toric lens is the way to go. When we're
Okay.
talking about presbyopia correcting IOLs, again, we're thinking even lower degrees of astigmatism. 1 diopter of astigmatism, because they're splitting light with these lenses, is definitely a very, very good option. If they want to truly be spectacle free, because they're going with that presbyopia correcting IOL, you basically do want to start to think about making that recommendation of considering the toric presbyopia correcting IOL. All of these lenses are getting great, great results.
Good.
And we as the optometrists should be educating our patients in that regard.
That's good. It's good to be able to kind of give them the heads up before they go to
Absolutely.
their
Yeah.
surgeon of what they should be looking for. And it's a good reminder.
Yeah.
Their refractive still doesn't matter after you take the lens out.
No, it doesn't. Yeah,
So it's
exactly.
just their corneal still. Yeah, yeah.
Yes. Yeah. Corneal sills where it's
Nice.
all at there.
Yes, yeah, good tip. All right. Well, if you haven't entered in any of your questions, if you have any remaining questions, go ahead and drop them in the chat below, and we'll hop on here in a moment. But otherwise, I think this is probably a good time to wrap this round of the series up. Our next series, we'll talk a little bit more about presbyopia and astigmatism. But
So
otherwise, thanks
join
for
us.
joining us. Yeah.
Yeah. Okay, it is questions and answers time. So, just as a reminder, if you have not, you could go to the bottom and you could click on the in the chat area, and you could type in your question. We do have, Aaron, looks like we've got 3 questions that have already been logged in there, so we could definitely jump into those first.
Yeah.
But if there's anything that's been top of mind as you've been listening to Dr. Roof and I talk, about this week's topic, definitely type it in, and we'll get to your question. So let's hop into the very first one. And this actually looks like that's definitely within your area of interest. So this question was, would there be any concern, would you have any concern correcting 100% of the astigmatic component of a child in regards to eyeglasses?
Yeah, that's a good question. I think the answer to that is I remember one of my optometry professors used to always say, it depends, right? So it depends a lot on the individual patient. I'll give you an example of when you might consider not correcting 100%. I actually had this patient in my chair earlier this week. I had a young teenager who was basically plano in one eye and was +6 with 4 diopters of SIL in the other eye.
Wow.
And she was actually pretty well, she was correctable in that eye. She wasn't amblyopic or not too amblyopic because she was about 20, 25, 20, 30. But that's an example of, I might consider cutting the SIL a little bit in that toric eye to allow her to adapt to the glasses a little bit better. And then we might over time slowly increase that SIL if and when she adapts to it. Also with glasses, you have to think about the differences in magnification and minification and anisoconia. So
Mhm.
again, that would be another example of when we might consider cutting. That's an extreme example. That's also a great example of when you might jump straight to a contact lens, right? And you
That's
should
true.
probably jump
Yeah,
straight
yeah.
to a contact
To
lens.
decrease that anisotropy that you're getting.
Yes, definitely. Other than in less extreme examples, I think about the symmetry of the astigmatism and the magnitude. So if it's pretty symmetric between the two eyes, even if it's a higher magnitude, I tend to try to push as much as they'll accept because it's going to be a pretty similar adaptation for both eyes. But again, it's sort of a science in the sense of you want to try to prescribe as much as they can tolerate, but an art of kind of understanding your patient, listening to their subjective responses,
Mhm.
and being willing to ease into the prescription and maybe change it over time and let a patient and mom or parent know that it might change over time, once or twice a year for the next couple of years as we adapt.
Yep. And when you're doing it with an adult, I mean, what I would always do, especially with adults, was that if I had a fairly significant shift in stigmatism or increase, um, I would just make sure I educated them really well.
Yep.
Letting them know, things may look a little tilted, maybe. The table may seem a little odd at first. So, do you do the same thing with the adults?
Absolutely. I feel like educating them about what they're going to experience helps them adapt a lot better. Similar, like I remember a college student I had once that came in with a lot of SIL that had been undercorrected for a long time. She was motivated to improve her vision. And just simply by educating her, she was motivated to like kind of put up with that adaptation in that short term to get the long term benefit. So, yeah, adults can understand what you're talking about. So, just getting them on board, making them part of the process, all of a sudden makes that maybe tilted, that kind of wobbly feeling a lot more acceptable to them.
So, I got new glasses today.
Oh,
Just
they look
picked
great.
up
Very
today.
nice.
I've talked about this a little bit, so the cylinder in my one eye keeps increasing. So I'm
Okay.
175 now in one eye. I'm actually just still a half in my other. And when I picked these up, knowing it went up a little bit, I was kind of tentative when I first put them on,
Right,
but
right.
adaptation was 100%. It was quick and easy.
Oh, love it. Love it. Yeah, that's good.
No, no problem.
Also, some tips, like don't put them on right in the middle of the day. Maybe try them out first thing in the morning when you wake up. Commit to wearing them right from your waking hour to when
Yes.
you're going to bed before you make any, judgments about what's happening. Yeah.
Perfect.
Yeah.
So question number two, I think this is one that we could both probably tackle.
Well,
And again, really interesting one. So thanks for the questions, folks. So this one is, what's the youngest age, Aaron, that you have fit? It's interesting. I mean, obviously we've been talking about soft toric, so that's really where the question is. But what's the youngest child that you fit with the soft toric contact lens? I don't know if it would really make a difference in my mind, soft toric versus soft, but still, just, if we kind of stay true to the question, soft toric with the kid, what do you think?
yeah. Well, I mean, personally for me, I don't usually see kids much younger than 5 or 6. If you're younger than that and I see you in your chair, I get a little nervous. But anyway, that being said, certainly when we talk about high SIL patients or even myopia patients, we're fitting them as young as, yeah, 5, 6, 7. Whenever that patient is has a refractive error that would require it, and or parent and or patient are old enough, mature enough, motivated enough to handle and be compliant with the lenses. I think it's great to keep in mind, as we mentioned earlier, you know, we can fit infants in contact lenses. We
Yes.
just have to make sure parent is on board and the need is there. So I don't think there's a too young age to fit a contact lens. It's you have to think about what the visual need is, and if you're identifying high amounts of SIL early in life, a contact lens is going to be the best visual stimulus to help their eyes continue to develop normally.
Yes.
What about you?
Same thing. Echo that 100%. I think it really comes down to motivation and maturity.
Yep.
So if I have, to be honest with you, if it was a 5-year-old that really had great motivation because of the fact there was, like I said, a big difference between the eyes and we saw the benefit, yeah, I would have no qualms about going very, very young. It's so interesting, when you fit those youngsters, when I was in practice, I would get all of the kids who had cataracts removed at day 2, at day 3, at day 4 from Will's Eye Hospital. They would send them
Oh,
up to
interesting.
practice. And at the time, we fit them with these Silsoft contacts. The amazing thing on an infant was they would be screaming. And as soon as you put that contact in, they would immediately stop crying
Hmm.
because they could see.
That's amazing. That's like such a I love my job moment. That's so great.
But again, I think it is having that child who has the motivation and the maturity to be able to handle it. I don't think there's a lower limit. Yeah.
I agree. I completely agree. Yeah. So I just saw a new question come in. This one says, when prescribing glasses or contacts for astigmatism, are there any considerations if the patient has refractive versus axial refractive error? Um, Good question. As a contact lens person, what I've always liked about contact lenses is you don't need to consider either one of those things, that it's
Mhm.
just about their overall refractive error when you put the lens on the eye. What are your thoughts, Kurt?
Yeah, same thing. I mean,
Okay.
optically, there's not really going to be a difference in that regard. So, um, I guess probably if we're talking about for myopia control, obviously we want to be cognizant of, where are we at with the axial length? Because that is really what we're interested in. But I think in this particular case, I don't really see a difference. Yeah.
Yeah, the kind of raw number you get in your phoropter is kind of the raw number you worry about. You don't have to think about
Mm-hmm.
in that instance where it's coming from.
Great.
Yeah.
We've got another one here. And this one's about the vertical imbalance. And it's funny, this is not the first time I've heard this question.
Oh,
We talked about, during the webinar, the fact that, with the soft torque contact lenses, you could get some, vertical imbalance that could be created because of having a contact lens that has prism or periballasting in one eye and none in the other eye, or maybe no contact in the other eye. So the question is that isn't the only concern with vertical prismatic imbalance only in regards to down gaze. And again, I've heard this a couple times from docs. And just as a reminder, yeah, that's true very often when we're talking about spectacle lenses, where we maybe have a plus lens in one eye, maybe a minus in the other. And as the eye is looking down, you're getting that prismatic imbalance because of the power difference. But in this particular case, where we've got the contact lens, that's not the case. The amount of vertical prism that's been measured in these contact lenses is in the optical center of the contact lens, and it has no regard in regards to down gaze. Actually, in down gaze, predominantly, you're still looking through the center of the contact.
mostly. Yeah. A soft lens doesn't translate on the eye in a meaningful amount to change how much vertical prism they're going to get when looking down versus when looking in primary gaze. It kind of stays in place generally. Now, there might be some measure of translation that's happening, but it's not a meaningful one.
So we could definitely probably bring back some really bad memories if we start talking about the amount of slab off that you might have to put in glasses. Remember those questions in geometry?
On my ophthalmic optics exams on part 1 of boards. Yeah, let's not. That right?
So I think we hit all of the questions. I don't see any other in there. So if that's the case, I think this is a wrap. I think so. First of all, thank the audience by all means for taking your family time out, maybe your dinner time to join us this evening. It was great having you all here with us. We're gonna have another one of these in a couple of weeks. We're gonna delve into the next big topic, right? Talking about soft multifocal toric lenses.
Awesome.
So,
sounds great. Thanks for joining us. Yeah.
Absolutely. It's good having you here with us. Thank you.